atherosclerotic, and then third one is called idiopathic. And clinical presentation can be similar to the acute coronary syndromes which we see, ranging from angina to sudden cardiac death. And spontaneous healing is also reported to occur between 4 weeks to 40 months. And there are no specific guidelines to treat a spontaneous coronary artery dissection, and that is very important because we have to take individual decision to treat these. And management of patients remains highly controversial. In particular, the value of specific medical regimens or coronary revascularization is debatable. So here is my first case, 53-year-old female admitted with complaints of chest pain and shortness of breath of 1 month duration. And she is hypertensive, hypothyroid, non-diabetic. And physical exam was unremarkable. ECG was suggestive of old anterior wall MI. Echo showed mild hypokinesia of the LAD territory with a E of about 45%. CAG done, which revealed a spontaneous dissection in the mid-LAD and a borderline lesion in the marginal. So we decided to go ahead with the PTCA. 6 French right femoral artery, 5,000 units of heparin, and preloaded with ecosprin and clopidogrel. XB3 was the guide catheter. Here are the pictures. Here you can see the dissected part, and you can see the true lumen and false lumen there. Then I tried to take a BMW wire and then try to pass it, but it was going into the false lumen. So then keeping the wire there, I advanced another BMW wire and then successfully entered into the true lumen. So you can see that after verifying that we are in the true lumen, proceeded to stent this vessel with a 3 into 38 ml8. It's a bare metal stent because this was done, I think, 4 years ago. And here is the final result on this LAD. And the second case is a 28-year-old young boy with severe chest pain while working in the farm associated with syncope. He was diagnosed an anterior wall MI. Subsequently, when he was having chest pain, he went to the local doctor in Warangal. He was referred to us for further evaluation. Echo showed moderate LV dysfunction. And you can see here, he has a spontaneous dissection in the ostial part of the LAD. And you can see here the multiple channels that are there. And this, we have taken a direct stent, 3.5 into 23, again bare metal, ML8 in this case also. And here is the final result on that ostium LAD. Good result. Patient did very well post-procedure and is on follow-up. The third is a 56-year-old male presented with anterior wall non-STEMI, fair LV function. CAG revealed single vessel disease, proximal to mid LAD, long segment SCAD, and planned for PCA with the DES to LAD. And here again you can see the 2 separate layers. This is called type 1 SCAD actually. There are 3 types, 1, 2 and 3. And here you can see that the dissection is extending almost up to the middle part. And again here we wired successfully into the true lumen. Then this patient received a long stent. For him the stent was not advancing, but it was a long stent, 48 millimeters Giant's expedition. So I had to do a little bit of ballooning in the proximal part of the lesion, and then I could advance the stent easily, 2.548 expedition. And here is the final result of this case. So these 3 cases we have, and in this so far, I think 3-4 years of experience. So briefly, what we found here is atherosclerotic or idiopathic maybe. Mostly it is associated with plaque rupture, and probably it is increased density of the vasovasorum due to atherosclerotic plaque, which may cause bleeding and rupture, leads to dissection. And majority of the cases underlying condition may lead to SCAD, cannot be identified. And there are other causes like morphons, SLE, vigorous exercise, and case reports are there where a prolonged sneezing induced a spontaneous dissection. So these are the 3 angiographic types. Type 1 is what we have seen here with the clear-cut lumens and contrast dye staining of the arterial wall with multiple radiolucent lumens. The technical challenge here is entering in the true lumen, because if you take the wire and try to negotiate into the false channel, you may extend the dissection and also may try to get a perforation or even close the vessel. So you have to be very careful, and the technique which I have used is a parallel while here so that it was successfully entered. And the type 2 looks almost like a spasm. And on follow-up, if you give nitroglycerin, it may open up. And on the table, you give nitroglycerin to this patient and see if the spasm opens up, it is a spasm. If not, then it is indicated to do a OCT or a IVAS to delineate. This is difficult to identify angiographically. And type 3 mimics atherosclerosis. Again, this is also very difficult to diagnose. So what we have found in our case is a type 1, which is very, very clear to see. And here is the algorithm that is given. High clinical suspicion of SCAD if you have, and the patients who do not have atherosclerotic risk factors, and young people, if they present suddenly during unusual exercise, that is one of the etiologies, and do the angiography. If you have a type 1 SCAD, it is definitive. If there is a type 2 or 3, then you give intracoronary nitroglycerin, perform OCT or IVUS, or repeat angiogram 4 to 6 weeks later. So if the vessel normalizes, that means the dissection has healed. In type 3, you treat as ACS, then perform OCT or IVUS, and then if it is a SCAD, you decide what has to be done.